I think we should go because we got a lot to do.
Okay, awesome. Let's start then. So good morning, good afternoon, and welcome everyone. My name is Marcella De Vita. I am a molecular oncologist by training, and I head patient advocacy and strategic partnerships at Monarch Bionetworks. And today with me for the 8th episode of the Monarch Connect with an Expert, I have Monarch CEO and founder Kamathi Stem, and Cardiopulmonary Rehab guru, Dr. Noah Greenspan. Hi, Kamathi. Hi, Noah. As Noah just said, we have a lot to cover in 1 hour and a half. So I'm just going to take 1 second to thank the patients of Monarch Interstitial Lung Disease Patient Research Network for suggesting the topic of oxygen. It is, as you guys know, a very controversial and complex topic. So here we are. But also 1 second to thank all of the 552 people who signed and registered to attend this meeting. Welcome for the one who are already online. I am going to show you very, very quickly. I'm going to borrow 1 moment of your time to show you what the webinar is going to look like. We're going to do a very short introduction of Kamathi and Noah. Then I'm going to hand the presentation to Kamathi, who will tell you a little bit about how Monarch is helping patients with interstitial lung disease live a healthier life. And then we are going to hand the presentation to Noah, who will talk about all things oxygen. And then we are going to close with just some available resources for people who want to get in contact with us after the webinar. We are all familiar with this slide. Yeah.
Just close your windows so that they can see the full slide.
Yeah, I don't think they can. Okay, perfect. I hope you guys can see us. So I'm going to start with introducing Kamathi. Kamathi is a biomedical engineer by training with over 25 years of pharmaceutical and biotech experience as a senior global leader across multiple companies like Genentech, Lilly, and AstraZeneca. Where she built and led multiple functional global departments. If you hang out at innovation conferences, you might have heard Kamathi speaking very passionately about a variety of patient-centric solutions that can really help people share their health data and digital data to accelerate research and participate in clinical trials, no matter where they live at any time. And Noah, I feel I really need to give a brief introduction about you. So as chances are that each of you on this webinar might have attended one of Noah's lectures or seen him speaking at a conference, or that you have participated in one of his many webinars, or actually might have read his book, The Ultimate Pulmonary Wellness. One way or another, I'm pretty sure you are familiar with the amazing work that Noah and his team do every day to serve cardiopulmonary patients in need. Dr. Greenspan is a board-certified clinical specialist in cardiopulmonary and physical therapy with more than 25 years of experience in physical therapy and rehab. Dr. Greenspan founded the Pulmonary Wellness and Rehab Center in 1998, and under his direction, the center has conducted over 100,000 exercise sessions, and these I didn't know had been named Best of United States in the area of cardiovascular and pulmonary physical therapy. So with that said, Kamathi, take it away.
Great, thank you. Thanks, Marcella. And Noah, thank you so much for joining us. It's a real honor to present with you, and to all the patients that are joining, thank you for giving us an hour of your time. We really appreciate it. As Marcella said, I have been in the clinical research space for many, many years, but personally didn't understand what it meant to be a patient looking for research until my sister-in-law was diagnosed with a rare cancer. And that's when I realized there are many, many patients that want to participate in research, but it's very hard to figure out how to, where to, and the enormous amount of work it takes to actually be considered. For my sister-in-law, we had to go to multiple hospitals and try to get her MRIs and her medical records and get it all organized and get it over to a trial center to be considered, and she also had to make some life choices as to whether she was going to travel 4 to 5 hours to participate in research, and did she have the financial means to do that. And so that really inspired me to figure out how can we make it more simple for patients to actually engage and be part of research. And we started in the pulmonary space primarily because when I was at Genentech, I was working on a drug that was being developed for the idiopathic pulmonary fibrosis. But then I realized, wow, this space is exploding. And so that's the good news today for all of you that are on the line. Research in the pulmonary space and new treatments are coming to clinical trials at a pace I've never seen before. And Marcella has done a beautiful job of kind of looking at what's out there in research right now. And what she's showing here is we have multiple conditions and the number of studies that are currently looking for patients to participate. And that's fundamentally the big difference that we need to make is if patients don't participate, we can't get new treatments to the market. But also sometimes a clinical research study might be the best treatment option for you. So how do we ensure that everyone has that opportunity, whether if they want to participate? And that's why Monarch was established several years ago. And what we wanted to do was we wanted to create a patient research network where we empowered patients, number one, to help organize their data into one personal health record that they can use to start improving their care today by sharing it with their caregivers and their clinicians so that they can have a better understanding of how they are doing, and all of the data across multiple clinicians can be shared in one holistic way, as well as help them have avenues in which they can participate in research, either by just simply donating their data in an anonymous fashion to help the researchers better understand disease progression, or actually participating in trials, and for Monarch to help them match to potential trials that are most relevant for them. So in our patient research network that we've launched, and right now it's for interstitial lung disease and for atopic dermatitis, and if you have other conditions, we'd love to still hear from you. But when you join the patient research network, we will give to you some tools, and the membership is completely free. We will launch and we will provide you with a mobile app that helps you collect symptoms in between clinic visits, so that when you go to the doctor and the doctor says, how have you been doing? You can actually have some things to share with them. You don't have to rely on your memory. You can say, hey, you know, a week ago I was really struggling, I was more fatigued, but today I'm feeling a little better. But if you look at the trend over a period of time, it can really help your clinician be better informed on how you're doing. It also has things like air quality index, where it will, oh, is it in a?
Yeah.
Oh, okay, let me come to that real quick then. The other tool that we provide is the Monarch Smart Health Record, which unifies your medical records from multiple providers. If you remember my earlier story of my sister-in-law, Tammy, she had like 10 doctors that she was going to manage her cancer. And it was really hard to get all of the records together, and to every appointment, we'd come with a big stack of a folder with a bunch of things and MRIs. In this with the Monarch Smart Health Record, we'll put all of your data into one one personal health record, where your clinician will be able to see it holistically across multiple providers and organize in a fashion. It will also help you, for example, if you've been prescribed certain medications and you can't remember the dose and this and that, that will be in your record. And so when the doctor asks you, you can just show them your Smart Health Record to help them understand what you've been prescribed and previous procedures that you might have had and so forth. So that's the Smart Health Record. And then the mobile app itself will help you track symptoms. So you can connect to, maybe you've got a pulse ox. You can either connect to a device that connects to Apple Health Kit or Google Fit or any of those different things, or you can manually type in your measurement that you've taken that day. It can track various symptoms. It can, if you have a flare, so let's say you have a rash or something, you can take a picture of that rash. As well as it has a resource section, which will give you the latest disease relevant news, as well as hear about things like Connect with Experts, like the webinar that we're doing today. And then finally, if you're interested, we can use that data to match you to potential clinical trials that are near you or that you can participate from the comfort of your home. There's a variety of things that we can do. And as you contribute more data, you'll be able to get insights from various trends. So for example, this particular screenshot is showing flares being reported over a period of time. Now we can also correlate that to air quality index because it'll passively start collecting what the air quality was like, pollution, pollen count, temperature, humidity, all of those things will be collected in the background, and you can start to correlate if there's any correlations between the two. Like, are there days where you have more trouble breathing than other days just because of the air quality? So those are the types of things an app can do. And if you join the Patient Research Network, which we encourage you to do, we'd love to share more with you about that and how you can participate in research. We have a new app that is actually being launched on April 9th, and so we're really excited. It has new features, and would love to talk to you more if you're interested. I think at the end of the talk, Marcella will be sharing more about how you can join the Monarch Research Network.
Yeah, briefly, yes.
Yeah.
Okay, and I am just gonna share this slide for a second. As you can see, it's a pretty robust agenda. Noah is going to walk us through a variety of topics, and he's going to stop here and there to take your questions, answer questions. So Noah, I'm going to stop sharing our screen so that we can see everyone in a more practical way. Take it away. Okay. Yeah. Noah, you are muted.
Well, that explains why nobody said hello when I said hello. All right. Good afternoon, everybody. Welcome. And I would like to start with a couple of questions. Just give me a couple of questions to get the ball rolling so I have an idea of what you might want to talk about. And does anyone, Judy, your hair looks fine. Don't worry. It's fine. Okay. Just this is webinar time. You look beautiful. All right. So does anyone have a question? If you have a question, raise your, okay. So a question from Kathy. Does my pulse ox say anything about my diffusion? Yes, it does, because if your diffusion is poor, then your pulse ox is going to be poor. Other questions, and then we're going to get started. Anyone else? Question? You can also unmute yourself and ask the question. Raise your hand if you want to ask a question. Sandy, do you want to ask a question? Nope. Talina wants to ask a question. Go ahead, Talina.
So this is a big one that comes up in the PF community a lot. Is there such a thing as too much oxygen?
Okay, perfect. It's on my minor list. Yes.
I have a question.
Who's that?
Donna.
Donna, what's your question?
With pulmonary hypertension, is there a point where oxygen can actually help the heart relax some versus just increasing your oxygen saturation?
Absolutely, I believe there is, and I will talk about that. One more question, and then I'm going to start running. Who else has a question? One more question. One more question.
Is it ever possible?
Jerry Albertson, I got to hear your voice, Jerry. Let's hear it.
What's up, Mr. Noah?
What's up, Jerry?
Just wondering, I hope you're well. Wondering what's the significance of a pulse index?
Okay, gotcha.
One of my oximeters has it on it.
So the pulse index is telling you how good your signal is. So that the lower the pulse index, the less reliable it's going to be.
Uh-oh.
But I'm going to get to that. I'm going to talk about this. All right. So let us get going, everybody. So one of the things, the most common thing that I see is patients who are short of breath. And one thing that I say over and over again is that breathing is multifactorial. Very often when you have a chronic illness, so if you have COPD, everybody assumes that your breathing is related to your COPD. If you have pulmonary fibrosis, everybody assumes it's related to pulmonary fibrosis. And if you have pulmonary hypertension, everybody assumes it's related to pulmonary hypertension. It may or may not be. And it's really important that we understand disease pathology. And for people who are living with a chronic illness, I think the more you know about your disease, the better. When I say that breathing is multifactorial, I mean that it's more than just the respiratory system, and it's more than just pulmonary function, and it's more than just oxygen saturation. What it could be related to are respiratory mechanics. It could be related to your cardiovascular system. It could be related to your level of conditioning or deconditioning. It could be related to weather. It could be related to the fact that you've gained 25 pounds. So you, God bless you. So you could see that whoever just sneezed, mute yourself, please. So as you could see, there are many, many different reasons why you can become either more short of breath or less short of breath without any change in your pulmonary function. And we know that. So when somebody comes to me and their pulmonary function is unchanged, but they're much more short of breath, or somebody comes to me and their pulmonary function is unchanged and they're less short of breath, what that tells us is that there have to be other factors besides just the respiratory system that contribute to how well or how poorly we breathe. I don't know if everybody here is in my group or not in my group, but the idea is, one of our mottos is yes, we can. And the idea is I want people to understand that it's not just medicine. Medicine is a part of the picture. And particularly here in the United States, medicine is treated as 80, 90, 100% of the equation, depending upon who your doctors are. Not that there certainly aren't holistic doctors out there, but in my formula, medication or medicine, or having the right doctor, taking the right medications and taking those medications properly, is really only 20%, okay? But exercise is so important for every diagnosis, whether you have COPD, pulmonary fibrosis, pulmonary hypertension. Exercise is the single best thing that you can do for yourself. Nutrition is crucial, okay? And a lot of people don't understand that it's not just a question of getting your vitamins and minerals or eating your vegetables or this or that, but depending upon the nutrients that you're eating, whether they be carbohydrate, protein, or fat, that can also significantly affect your breathing and significantly affect the amount of CO2 in your blood, carbon dioxide. So what I mean by that is that carbohydrate, okay, carbohydrate metabolism produces the most carbon dioxide of any of the nutrients, okay? Protein produces the next most, and then fat produces the least. So what that means is that if you have a high carbohydrate meal, that can spill a lot of carbon dioxide into your blood, and that increase in carbon dioxide along with pH is what causes you to breathe. So we know that when you eat, you have food in your stomach, and a lot of people have a difficult time eating big meals, but a lot of people have a hard time eating any meals. Because why? The diaphragm sits right above the abdominal contents. So if I have veal parmesan and spaghetti and bread and 2 drinks and dessert in there, then the diaphragm that sits right on top has to work that much harder to contract against that. And then, hold on just one second. And then the lungs are going to be compressed up, and the lungs are not going to be able to expand as much. So eating is not just about how much do you weigh or are you getting the nutrients. It has a lot to do with breathing. And so that's very important. Stress and anxiety, okay? Who here is not stressed besides me? Everybody's stressed, right? So having Bruce, you're not stressed? Wow. All right. Well, okay. So here's the thing. So stress plays a huge role in shortness of breath, okay, in how you feel, in terms of anxiety, in terms of depression, et cetera, et cetera, et cetera. So it's very stressful and very anxiety provoking to not be able to breathe. So if we think about COPD, pulmonary fibrosis, and pulmonary hypertension, the commonality between those three is shortness of breath. And a lot of times people get into like a little match between like, hey, this isn't for me. This is for people with COPD. I have IPF. This isn't for me. This is for somebody with pulmonary hypertension. I have COPD. Trust me, I see all these types of patients, and the treatments, although the medications are slightly different, the lifestyle issues are the same. And very often patients, when they're diagnosed with a chronic illness, what winds up happening is their entire existence becomes around that illness. And what I mean by that is that it all becomes around taking your medicines and going to the doctor and going to the pharmacy and picking it up. And often our lives become these sort of black and white monochromatic versions of ourselves that are completely devoid of any type of art, music, fashion, color, et cetera, et cetera, et cetera. It's like the Wizard of Oz, except we're going backwards. We're going from color to black and white. And what I try to do over and over and over again is I try to teach people the things that will help them get their lives back, okay? One of the things about Pulmonary Wellness Online, our motto is inspired by life, okay? Inspired by life, because if your life is nothing, if you've been reduced to just being a disease, how many people think that quality of life is equally, if not more important than quantity of life? I definitely do, okay? And there's certain sayings that I will repeat, certain quotes that I think are great, and think about these. Probably everyone in my group is gonna know which ones I'm gonna talk about right now, but one by Martin Luther King, it says, if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. And I had a discussion with Martin and added, if you can't crawl, then breathe, because there is always something that you can do to improve the quality of your life. I'm looking at the screen. You're all very good looking, but I know that not everybody here is paying full attention to their medicines, is not paying full attention to their exercise, nutrition, stress management, and prevention of infection. So there is always something that you can do. And when a physician says to me, there's nothing more I can do for you, that's when I decide to look for another physician, because I believe there's always something that you can do, and there's always something that we can do to make your life better. The other quote is, don't let the things that you cannot do interfere with the things that you can do. John Wooden, famed UCLA basketball coach, won 10 national championships. Don't let the things that you cannot do interfere with the things that you can do. So think about it. People get diagnosed. I have COPD. I better go get into bed right now and wait to die. Oh, I have pulmonary hypertension. I better go and get into bed and wait to die. I have pulmonary fibrosis. I better get into bed and wait to die. Because what people say to you, and I hate the stuff I read online a lot of times because it's the same stuff, and people say to you, you know what? COPD is a chronic disease that gets worse and worse. You'll become more and more short of breath, weaker and weaker, and then that's it. Uplifting article. Thank you for that. You know what I'm saying? It's like, I feel like saying to people when I read stuff like that, why are you taking the hope away from people? The other thing I'll say is that a lot of times when people hear me talk, they think that it's like, they think I'm selling snake oil, okay? But look around. I mean, this is the Pulmonary Wellness and Rehabilitation Center that has been here for 20 years, and we wouldn't be here if we were selling snake oil, okay? And I have to face you. So this is not stuff that I think. These are things that I absolutely know work, and they can work for you too. So when somebody says to you, that's it, there's nothing else you can do, then, you know, or you know what, don't expect to get any better, or this and that and the other thing. I already told you that it's not just pulmonary function. So even if your pulmonary function remains exactly the same, then you can still improve other things and improve the quality of your life. Any questions so far? All right, so Anne from Indiana. Yes, ma'am.
Can you hear me?
I can.
Okay. You mentioned the carbs, the proteins, the fats.
Right. What?
Can you hear me? You mentioned the carbs, the proteins, the fats.
Right.
How they affect your lungs eventually. How does alcohol play into that? Drinking alcohol. So
alcohol is carbs and sugar, okay? So it's also a central nervous system depressant, okay? So it could suppress respiration as well. So as part of the big picture, it could suppress respiration.
Okay, thank you.
Yep. All right, so how your body utilizes oxygen is based on three main factors, okay? How good are your lungs at moving air in and out? and how good are the molecules of oxygen at getting into your blood? How good is your heart at pumping blood? How good are your muscles at utilizing oxygen, okay? All three get better with activity. All three get worse with inactivity. So think about that. It's like a triangle. They all work together. So if you think about a car, okay, if your spark plugs are old and dirty, if your oil filter is filthy, if your tires don't have the right amount of air in them, each one of those things will take away a little bit from the overall. Stephanie, stop showing off, okay? She's got to work out during the webinar. So you know, the thing is that each one of those things contributes to the overall efficiency of the car. Now, if you have those things that I said before, and you change the spark plugs, guess what? You're a little better than you were before. If you now change the oil filter, you're a little better than you were before. And if you now, you know, put the proper air amount inside, you're that much better. But the thing is that all three work well together. But even if you change one, so somebody will come and they have heart disease, okay? Okay, that's a limiting factor. It's a consideration. We have to take it into account, but it's not everything. COPD, we know you're gonna be affected in terms of how your lungs move air in and out. Same thing with pulmonary fibrosis, okay? But it's not everything. And if we can improve the strength of your heart, which we can, and if we can improve the strength of your muscles and the efficiency with which your muscles utilize oxygen, which we can, then your life gets better. The big thing about shortness of breath typically will come on at high levels of activity. So the things that I hear over and over again, walking upstairs, walking uphill, running for the bus. New York City, walking up the subway stairs, walking up a hill, and running for the bus. New York City pulmonary triathlon. But the thing is that when people start to get short of breath, and when they start to have discomfort, and it really doesn't matter what that discomfort is. It doesn't matter if it's shortness of breath, doesn't matter if it's hip pain, back pain, knee pain, chest pain. They will find ways to avoid the activities that cause them discomfort. And when you do that, all of the muscles of the body, all of the systems of the body will become less efficient, will become poorer at using oxygen, and then you start to become short of breath at lower levels of activity, and then you stop those, and so on and so forth. This is what we hear as referred to as the shortness of breath cycle or the dyspnea cycle, okay? And key and crucial is to break into that cycle by A, learning more effective breathing techniques, and B, learning how to exercise so that your body gets better at using oxygen. So how many people here use oxygen, supplemental oxygen? Raise your hand. Is there anybody that doesn't use supplemental oxygen? Okay, for the people that don't use supplemental oxygen, how many of you take inhaled medications? Okay, so here's the deal. So we gotta learn a few things here, and some of these principles apply to everything that we talk about. So what I try to do is I don't want to give you a list of things to memorize, okay? And I also don't want to give you one tool, right? So it's like if I give you a tool and I give you a fork, right? And that's your tool, and then I serve you some soup. Your tool is now rendered useless, right? But if I give you a fork and a spoon, well, now you have two options. And if I give you a fork, a knife, and a spoon, then you have three options. And the thing is that in 90% of what we do, I would say probably even more, 100% of what we do, there are always going to be, hold on just one second. There are always going to be things that we can do and things that we could change. But the more things you have in your repertoire, the better off you're going to be. So it's like when a fire truck pulls onto a scene, you notice that each guy comes out with a different tool because you never know what they're going to need inside the fire. And for you guys, what I'm trying to do is I'm trying to get you to have as many tools as possible so that you don't memorize what I say, but so that you can say, you know what, this is a hill. I have this I can try. I can try breathing techniques. I can try to relax my airways. I can try to take my medication, or I can try stress management if it's an anxiety issue. But the key is to learn as many of these things as we can. So why would somebody need oxygen? Okay. Does anybody want to take a guess at this? Why do you need oxygen? First of all, we all need oxygen, right? Whether you use supplemental oxygen or not, We are all oxygen addicts, right? We're all addicted to it. Without it, things don't go too well for us. Somebody got upset. I said oxygen addict the other day. But shortness of breath is based on many different factors, okay? When we prescribe oxygen for people, or when people get prescribed supplemental oxygen, it usually has to do with a problem with gas exchange, okay? And how do we know that somebody has a problem with gas exchange? There's two main ways that you can know this. One is called an arterial blood gas, and the other is pulse oximetry, okay? So if you go below 90% in general, that is the indication that you probably need supplemental oxygen. Now, the problem with that is that many insurance companies, okay, including Medicare, require you to be at 88% or lower in order to qualify for supplemental oxygen. Now, some people may say, well, what's the big deal? It's only 2 percentage points, okay? Let me explain to you what the big deal is, okay? So if you look, there's something called the oxygen hemoglobin dissociation curve. Can everybody just check to make sure they're muted for a second, please?
Yeah. So Noah, I'm not sure if people have a few questions. I think
What's that? What?
I think Diana might have a question, maybe?
Yeah, I will get to questions in a couple of minutes once I set the stage for the question.
Okay.
So the idea is that people, you know, why do you use oxygen? Okay, there's this thing called the oxyhemoglobin dissociation curve. And what that has to do with is how good, you know, how well your oxygen is going to be carried on the hemoglobin. And the thing is, it's not a linear curve. So if you look at my arm, linear curve means that it goes like this, and every percentage point is equal, right? Except that this curve is what we call sigmoidal or S-shaped, okay? And it looks like this. So up at the, I could do, I'm not gonna make any political jokes. I was gonna make a funny political joke, but I decided not to at the last second. Okay, so the thing is that between 100 and 90, okay, the curve is very flat, except that at 90, it drops off again, and then it levels out again. So think of it like an S-shaped snake, right? So between 90 and 100, you're good. And think of it like this. I want to take your picture, and you want to photograph. We're on vacation, and you asked me to take your photograph with the Grand Canyon behind you, okay? So I'm going to take your picture. We're 10 feet from the Grand Canyon. So 190, so that's 100 to 90. We're 10 feet. So you could go back anywhere between 1 and 10 feet. But if you go that 11th foot, your life changes very quickly. And it's the same thing when you go from 90% down to 89% and 88%. Really, Medicare should bring the number up to 90. But there's also, you know, there's a lot to consider with that as well. Does that make sense to people? So if your oxygen drops below 90%, okay, you should be on oxygen. Now, there's two different things that I want to just make clear here. Shortness of breath does not always equal saturation, okay? So what I mean by that is that you can be very short of breath and your oxygen saturation can be 95 or 96%. And that's a question I get a lot. People say, well, I don't understand this. How can I be short of breath if my oxygen saturation is 97%? And the answer to that is it's multifactorial. There could be many reasons why you're short of breath. You could be 50 pounds overweight. You could have COPD, in which case you have air trapping. You could have pulmonary fibrosis, in which case you have difficulty moving air in to the lungs, okay? So the key point in what I'm saying right now is that if you're hypoxic, or rather, if you are short of breath, but your oxygen is good, oxygen is not going to help you at that point, okay? So if you're short of breath and your oxygen is anywhere between 90 and 100, think of a glass of wine and the glass of wine is full, right? So any extra wine we put on there is wasted. It's gonna go out on the table. So between 90 and 100, the oxygen is not going to help you. That is not an indication for oxygen. And then there are other things that you could do. So let's say you're walking up a hill and how many people have pulse oximeters? Okay, great. A lot of people have your pulse oximeter. And I recommend that you get a pulse oximeter because you cannot tell your oxygen, okay? It's very difficult. There's people who believe that they're like that guesser at the carnival and they think they know their oxygen saturation, like in the same person who can guess your weight or date of birth or, you know, month weight or age. Very often people are off, okay? And more often people are off than not. So you may feel that your oxygen saturation is 96%, and we may take it and you may be surprised to find out it's 85, or you may be so short of breath and I say, well, what do you think your oxygen saturation would be right now? And you say, it's gotta be in the 80s, and we check it and you're 96%. So if your oxygen is good, I'm gonna tell you about two different types of people. If your oxygen is good, but you're very short of breath, what can you do? Okay, number one, stop whatever it is that you're doing that's making you short of breath. So nobody catches their breath by continuing to do the thing that makes them short of breath. So if you're walking up a hill and you're getting more and more short of breath, you must stop in your tracks, okay? And start the controlled breathing techniques, things like recovery from shortness of breath. And there are different positions that you can get into that will actually improve respiratory mechanics and allow you to catch your breath more quickly. And that's called recovery from shortness of breath. And then the other thing that you could possibly do if it's a question of bronchospasm is you can take your rescue inhaler, okay? So that's for the person whose oxygen is good. That's not gonna be, oxygen won't be a help, but stop what you're doing, controlled breathing techniques, rescue inhaler. And if you can predict when you're going to get that way, so if you know that every time you walk to the grocery store at the second block, you start to get short of breath or you start to get some tightness in your airways, then you would benefit from taking your rescue inhaler 15 minutes before you go out so that you can essentially pre-medicate. So hopefully you won't get that shortness of breath. Now here's something else. Let me just, so here's the other side of the coin. The other side of the coin is the person who is hypoxic, meaning hypoxia means are not getting enough oxygen to the tissues. Hypoxemia means you're not getting enough oxygen in the blood. But for the person that is hypoxic, but who is not that short of breath, that's a trickier individual because that person very often doesn't see the need to use their oxygen, okay? But here's what I need to tell you about that, okay? Even if you're not short of breath, when you're hypoxic, the risk of coronary insufficiency, the risk of coronary ischemia, the risk of arrhythmia, the risk of pulmonary hypertension, the risk of heart failure, all go up, okay? So whether or not, you're short of breath or not, and in all likelihood, you would be short of breath, but essentially, if you're dropping below 90%, you should be on oxygen. And if you're dropping below 90%, even if you're on oxygen, then we need to talk about the fact that your device that you're using is not adequate in order to meet your needs. And if the device is not adequate to me, it's kind of like an all or nothing thing because of what I told you about the oxyhemoglobin dissociation curve. So like if we go into an elevator or if 2,000-pound guys go into the elevator and they look at the weight limit and the weight is 500, it doesn't matter, okay? It's not gonna be adequate. So it's like all or nothing, and it's a similar type of thing. Patients come to me all the time and they're on their portable oxygen concentrator and their saturation is very, very low. And in that case, we have to find out, number one, is the device adequate? And they also need to know how to use that device adequately. Okay, let's go to some questions.
No,
who has a question? Yep.
No, we got a question that I would like you to address. It's like, what are those positions to improve your breathing?
Why do they improve your breathing?
What are those positions to improve your breathing?
Okay, so first of all, if you're sitting, okay? If you are sitting down, okay? Spread your knees very far apart, lean down with your elbows on your knees and lean forward and do pursed lip breathing, okay? If you're standing up, I can straighten my arms and lean down on my knees like this. I can lean against a wall and lean like this. I can go like this. All of these positions are described in my book, Ultimate Pulmonary Wellness. there's my first shameless plug of the day. And the thing about that is that, why do these things help? Okay, I talk about open chain versus closed chain activity. So what open chain activity means is this. Open chain for my arms now means that my arms are free to move around in space. When I fix my arms on something, think about a treadmill or something like that, that's called closed chain. And then all of the muscles of my thorax, my chest, my back, my shoulders, instead of moving my arms like this, what they do is they help to elevate the rib cage. And that's why a lot of times people say, well, why can I walk for 30 minutes on the treadmill, but as soon as I get outside, I can't breathe? And for people like that, what I recommend is a rolling walker. And people don't usually want to hear that because they see it as a step in the wrong direction. But the thing is that by allowing you to fix the upper body, closed chain activity, it helps with respiratory mechanics. The other thing it does, it helps your abdominal contents drop forward. That's essentially the reason. So a lot of people, you probably noticed that when you're in the shopping, you know, in the shopping center, in the supermarket, a lot of people probably lean on the cart, right? And they're like, wow, this is great. I should stay in the supermarket all the time. I can breathe here. But it's not the supermarket. It's the leaning on the cart and the closed chain activity. All right. Why does the, I can't, why I have no sound? I don't have a camera. If you don't have a camera, that is okay. You can still participate. How do you find the app? The app will be available for free. I don't use it. Inhale. Okay. It's going to be impossible to search through this chat through the entire thing. If you have a question, please unmute yourself. Ask the question. I'm happy to answer it. Does anyone have a question at this moment?
I do.
I do.
Brian.
Hi. Noah.
Brian, I saw the picture this morning on Facebook.
Yes.
Yes.
I have oxygen coming
You
out
have
of every.
liquid oxygen.
I've got 2 large tanks of liquid, a liquid flask so I can go out, a large tank as an emergency, and a concentrator with low input, but quite good for when I'm just sitting around at home.
Yes.
How do I make best use of all that?
Okay, so let's talk about that right now, okay? So when we talk about oxygen, okay, okay, there's a construction saying, there's a construction joke amongst contractors. And what they say is everybody wants 3 things from a job, okay? They want it to be done well, they want it to be done fast, and they want it to be done cheap. And the rule of thumb is you can have any 2 of the 3, right? Now, when it comes to oxygen, okay, when it comes to oxygen, everybody wants 3 things. What are they? They want it to be light, they want it to give a lot of oxygen, and they want it to last for a long time, right? You could have any 2 of the 3, okay? It's that simple. So if you look back here, I also have a bunch of oxygen, okay? And oxygen is gonna come, okay, in many different forms, but this is the most standard that people see. This is a cylinder, okay? And what this is this is 100% gaseous medical grade oxygen, okay? You can have, I don't know if you can see this or not. Oh yeah, you could see it. It's this right here. This is a stationary oxygen concentrator, okay? This is a portable oxygen concentrator. And then the other things that we have are liquid oxygen, and liquid oxygen is getting a lot of attention in the news these days because it is getting taken away from people, and it is getting harder and harder and harder to find liquid oxygen. A, because it's more expensive, it requires more service. And what happened, you know, due to legislation a few years ago is it stopped being an affordable thing, and a lot of the companies that were providing it either stopped providing it or went out of business altogether. So let's talk about from best to worst, and keep in mind that best to worst is going to be situational. So Brian, I'm glad you asked that question, because what I want you to be able to think about, people, is I want you to be able to think about how are you going to maximize the use of the oxygen. So let's say it like this. So let's say you're just sitting around at home doing nothing, right? Or watching TV. What do you think is going to be the best one to use at that time? Anyone? Anyone? How many people think
The static concentrator.
stationary concentrator? Okay, why is that going to be the best one to use? The reason why that's going to be best to use is it's going to plug into the wall. As long as you have electricity, it doesn't stop producing oxygen. It's continuous oxygen, right? And there's a difference between continuous and pulsed oxygen, and it's a big difference. And the other thing about it is some of them can go as high as 10 liters per minute, okay? So that's the plus. Those are the pluses of a stationary concentrator. Connected to electricity, lasts as long as you have electricity, okay? Gives you a good amount of continuous oxygen. The one I have, it goes up to 5 liters, and some go as high as 10 liters. And you know, it's important that you understand those things so that you can make sure that you get the right equipment, okay? Now, what's the downside of this? If this is all I have, then guess what? That is not the way, that's not gonna be easy for you to get around, right? So I said that you got 2 out of 3. So this one gives you a lot of oxygen. It lasts for a long time, but it's not small and lightweight. But that's the best thing to use at home. And in addition to that, besides just the 7-foot cannula, you can also add a lot of tubing to it and not lose any of the benefit of the oxygen, okay? Does that make sense? Any questions about that? Now, when is that gonna be a problem? So let's say now we wanna go out, okay? And this is where the portable oxygen concentrators came into play, okay? So this is a portable oxygen concentrator, okay? And what this is this is the Inogen 1 G3. Now, this is a good time to talk about the difference between continuous oxygen and pulsed oxygen, okay? And like the name sound, continuous oxygen will flow continuously into your nose, whether you are breathing in or out. Pulsed oxygen is designed to trigger when you breathe in to conserve the oxygen. So if I put this in my nose and you listen carefully, okay? You hear that? So what you should be hearing is that each time I breathe in through my nose, this triggers some oxygen, okay? Now, there are some super duper crucial points that have to be made at this time regarding continuous versus pulsed oxygen, okay? What is the dosage? So when we talk about continuous oxygen, we are talking about liters per minute, right? So 1 liter per minute, 2 liters per minute, 3 liters per minute, 4 liters per minute. Now, when we're talking about pulsed oxygen, okay, and I don't care if it's a portable oxygen concentrator that gives you pulsed, or one of those regulators that has a conserving device that only gives you oxygen on inhalation. If we are talking about pulsed oxygen, you have no business calling it liters per minute, because it is not. And that is one of the biggest misconceptions in the oxygen world, and even by clinicians, okay? So this machine here goes from 1 to 5, but that does not mean 1 to 5 liters per minute. And in fact, and I'm just gonna use this as an example because a lot of times people don't understand why they can do so well in pulmonary rehab when they have 5 liters per minute or 6 liters per minute, and then they get on this concentrator and they turn it all the way up to 5 and their oxygen plummets. So for those of you that don't know this, okay, paper, it's called the Pulmonary Paper. And it's a really terrific paper. Celeste Bellier is the editor. And one of my buddies who I consider to be one of, if not the most knowledgeable person about portable oxygen concentrators and oxygen equipment is Ryan Deesum. And every year Ryan puts out something called the Portable Oxygen Concentrator Guide. And that is about to come out in the next issue, www.pulmonarypaper.org, okay? And in it, he has all of these different units here, and it tells you all about the different units. So now, just using this as an example, okay, the Inogen 1 G3, even though it has settings of 1 to 5, listen to what I'm about to say, has a maximum oxygen production of 1,050 milliliters per minute. You know how many liters that is? 1.05 liters per minute. So that means turned all the way up, this device is only going to give you 1.05 liters per minute, okay? So what does that mean, okay? A lot of times I see people with machines that are grossly inadequate for them. They come in, they're at 60%, 70%, 80%, whatever it is. If the machine is not able to keep you in the 90s, then it is not adequate for you, okay? But there's something else that you have to keep in mind also. Many people do not know how to use their machines, okay? And I don't think I've ever talked about this before in a meeting or anything like that, but I've been saving it for you guys, okay? How many people use a portable oxygen concentrator? Raise your hand. Okay, pulsed or continuous? 2 fingers for pulsed, 1 for continuous, middle finger if you're getting tired of this. All right, good, I don't see any middle fingers, that's good. Okay, so most people are using pulsed. I'm sorry, I forgot what I said, 1 and 2. Who is using pulsed? Okay, continuous? Okay, less people. So with a portable oxygen concentrator, okay, how many people that are using continuous, put up how many fingers of liters per minute is the maximum? So, no, Stephanie, you put up 4 fingers. You're putting up 5 fingers, Kevin, and I knew that was wrong, okay? So here's the thing. No portable oxygen concentrator gives more than 3 liters per minute continuously. Okay, that's what I'm saying. Zero. There are not any units on the market that give more than 3 liters per minute continuously. So if you're saying 5, Kevin, okay, that means you may have 5 settings, but that is not liters per minute. And that is the important thing to keep in mind. So I'm going to go back to this chart here, okay, which I was just showing you, to the Inogen 1 G3 Oxygo that I told you already can only give you a maximum of 1.05 liters per minute. And if you think about it, we have patients that when they come to rehab, if we want to push them, we'll give them 10, 15, some of them we give 25 liters per minute of oxygen in order to get them to do the workout that is going to make them the strongest. So 1.05 liters is like 4% of that. Now here's the thing. The maximum delivered pulse volume, okay, if you're breathing at 15 breaths per minute is 67 milliliters, right? If you double your respiratory rate, now this is another misunderstanding, okay, is that people think that if they start to breathe faster, as we all do, okay, you're actually getting less, right? You're actually getting less per dose. So if you go from 15 breaths per minute where you're getting 67 milliliters, if you double your respiratory rate to 30 breaths per minute, you're actually getting half that, 33. So imagine this, you had a party planned for 12 people, 25 people show up, you have the same cake, guess what? Everybody's getting half the amount of cake. Because if you gave the same pieces after the first 15 breaths, everybody would be out of oxygen. So key points from that, I know I said a lot of things right there, but what's really important is that you know that you're not getting liters per minute. It is a factory setting. And a term that I use, because people are starting to wake up to this fact a little bit, I'd like to think I have a little something to do with that, but a lot of times people say an arbitrary setting, okay? And I wouldn't say it's arbitrary because arbitrary is kind of random. It's not a random setting, but what it is it's kind of a nominal setting, okay? So definitely 1 is less than 2, and 2 is less than 3, and 3 is less than 4, and 4 is less than 5. But don't get the idea that you are getting 5 liters per minute. And that's a really important point. So what do you do if none of these concentrators will do the trick for you, okay? In that case, my recommendation is always a tank. I love a tank. Okay, I think a tank is the best form of oxygen because it's 100% oxygen. Now, is it easy to carry a tank around? Absolutely not. For some people, if you have pulmonary fibrosis and you know, for many people, you need a lot of oxygen. I only had one patient who ever really did what is necessary, which is what she did was she pushed a cart and she had 7 E-tanks and she used a mask, okay? So that's incredible if you think about it, and I'm not advising you to do that. I'm just trying to say to you that what I don't want is I don't want you thinking that you're adequately covered and you're really not adequately covered. And I don't want you buying a $2,000 machine that doesn't meet your needs, okay? And that happens a lot too. And so another thing to think about is this. Anyone ever gone scuba diving before? Okay, so you know how a scuba tank works is you take a breath in and the air comes out. If you don't take a breath in, the air doesn't come out. In many cases, that's how these portable oxygen concentrators are, okay? And what I see a lot of people do is they take a breath or they trigger the machine and they hear that and they think that now they're being oxygenated, okay? Here's the problem with that. Anyone know what this is? It's a trachea, okay? It's a windpipe. And it's about this big, okay? If you put your hand on your chest and you'll feel a little horizontal notch here, that's called the angle of Louis or the sternal angle. And that correlates with where your trachea or windpipe becomes right and left main stem bronchus. Now, the average person's airways and the average airway person's trachea will hold approximately the number of milliliters of oxygen as they are weighed in pounds. So if we have a person who's 150 pounds, imagine there's 150 milliliters of air that goes in here, okay? That air that you have to bypass before it gets anywhere near the lung and where it could get into your bloodstream, right? So if you think about breathing pattern and how important that is, okay? If you're going like this, that oxygen is going, and it's not getting into your lungs. So you are getting more and more short of breath and your oxygen saturation is going down, down, down. So really important in terms of using your machine is the idea that the only way that that oxygen is going to be beneficial for you and a way that you're going to maximize and conserve the most oxygen is that when this machine triggers, okay, you have to not just hear the dose, because if you're taking very short breaths, then what's going to happen is on your next breath out, all that oxygen is going to go, it's going to go away. So what you have to do instead is you have to go. Because if it does not pass the trachea is called anatomical dead space, because nothing that's in here can, imagine like it's like that part of the plane from the waiting area to the plane. Nothing goes on there, right? If all of a sudden the plane separates from that, you're stuck in that thing, nothing can be used there. You can't go back to the waiting room, can't get onto the plane. But that is why when this thing's triggering on its own, some of them are set at a minimum pulse. So if they're not gonna actually trigger by me stimulating it, then it will trigger on its own. But for me to get the maximum benefit from this, I have to. Okay, any questions about that? Does that make sense to people?
Yeah. Thanks,
Brian.
You rather skipped over liquid. It sounds as if in the States you haven't got it. I'm in Europe, so the norm is liquid. So what arrives every week is two 30-liter liquid tanks. And this is my portable, which goes up to 15 liters a minute.
Yep.
I fill it from the big tank and away I go. And the world is
if you have access to liquid oxygen, that's your best bet. And the reason why liquid oxygen is so great is because liquid oxygen is cooled and compressed into a liquid. And then as it starts to warm and as you start to use it, it starts to go back to a gas, and it's the most efficient form. So ideally, anyone who's on supplemental oxygen would have liquid oxygen. And the beauty of what you have there is that you fill your tank with it. And you're right, as you said, the world is your oyster, because it's pretty lightweight, and it does give you, it's the closest thing to giving you all three things at once, which is the closest thing to giving you high oxygen flow, lasting a long time, and All right, the nurse is in the house now. What's going on there? What hospital are we at? But you see what's going on there is that that's the most one that's going to give you the closest to it. But it's very, very difficult to get here in the States. So if you can get it, awesome. Now, there's a couple of other things that you can do to also improve the efficiency of this, okay? A cannula is not very efficient. And a cannula is really only effective when it goes up to about 6 liters. Once a patient needs more than 6 liters via nasal cannula, and again, I'm talking about 6 liters per minute of pure oxygen, then I recommend that we start using a mask, okay? And this right here is called a non-rebreather mask. And the beauty of this is that this reservoir bag will actually fill up with oxygen, and so that when you take a breath in, you're not just getting what's in, you're not limited by the size of the cannula, you're actually getting this whole bag that's full of oxygen. So you're getting a very high concentration of oxygen. Now, here's the thing about this. Many times when I talk about this, people will tell me, guess what? You can't use that mask unless you're using at least 10 liters of oxygen, or you can't use that mask unless you're using 15 liters of oxygen. And the fact of the matter is you can. As long as you're using 6 liters or more, and in some cases you can even use less. This is specifically hooked to my concentrator because I wanted to show you that the lowest form of power on only 5 liters per minute is filling the bag, right? So with this, and in all the situations, it doesn't matter what form of actual oxygen you're using, the key is always going to be to try to take the deepest breath possible so that that air can pass the trachea and get into the lungs. Now, here's the other thing. There's something called transtracheal oxygen, okay? And transtracheal oxygen is a delivery system in which it's actually a surgical procedure, and you get a tube that's put into the trachea. And the beauty of that, and it sounds a lot worse than it is, and it's significant because it is a surgical procedure. It's something that you have to clean. It's something that you have to keep tabs on, but you bypass this whole thing. So that means that anything that comes goes right to the source into the lungs. Any questions about that so far? Any questions about anything we've spoken about so far?
Noah.
Yes.
My question is, I think you've answered it, but I sleep on 2 liters of oxygen from a tank or a concentrator.
Okay.
But I once or twice when I've traveled have used my portable concentrator, which is pulse, to get by. But I think what you've just described says it might not be really getting to my lungs to use a pulse in that situation.
So sleep is a little bit of a different situation, okay? What we're talking about here is all based on supply and demand. So the more vigorous the activity, the greater the demand and the greater the supply you're gonna have to have. The reason why sleep is such an issue, there's multiple situations with sleep. So number one is that you're gonna be breathing much more shallowly, okay? So then it becomes a question of the fact that different systems have different sensitivities, right? And some of them, you know, you have to take a little deeper breath to trigger it. You may not be taking the deep breath, et cetera, et cetera. Now, there are studies out there that have shown that it is effective, okay? And people, you know, can get adequate oxygen using a pulse system. My feeling, okay, even though I've read the research, is I personally would not want to do it, okay? Bill Maher does a bit. It says, it goes like this. It goes, I don't have any proof. I just know it's true, okay? And that's the same kind of thing here. Like for me personally, if I am gonna use oxygen at night, I am going to use continuous, okay? Now, again, what are the problems with being hypoxic? I told you. So it's coronary ischemia, it's coronary insufficiency, it's arrhythmia, it's heart failure, it's the potential to have a myocardial infarction. None of those sound as good as carrying your continuous oxygen with you and using it, right? So it's, in my opinion, it's risky. And I know there's research out there that says it's okay. Just understand that the research is not, there's no person that's going to be consistent with everything in the research. So if you know, the research may say it, I still know there's going to be people who are not going to be adequately oxygenated with it. I know there's going to be some people who are going to be adequately oxygenated with it. And guess what? A lot of the people who are adequately oxygenated on pulse probably would have been adequately oxygenated even if they weren't on oxygen. Now, here's another thing to think about. How do you know if you need oxygen during sleep? Okay, up until pretty recently, you would have a sleep study, and the sleep study takes place in a sleep lab, and you get a whole bunch of stuff done. And what's easier now is what's called an overnight oxygen study, and you get something like this sent to you at home. It's a watch, right? Not a very stylish watch, but I'm trying to get one like this. I'm trying to get Hublot to sponsor the overnight oxygen studies. But what this does is this will measure your oxygen saturation, okay? But what it doesn't tell you is sleep apnea, okay? And that's a totally different ballgame. And what sleep apnea is where you actually stop breathing for different times during the night. Now, it doesn't mean you go completely zombie, okay? But it could mean that you have periods of hypopnea, hypo meaning lower, or apnea where you stop breathing. And the problem with this is that you're not getting oxygen. So if I'm giving you oxygen, but you're not taking the breath, it's not doing you any good. So if, you know, that's the other thing. So if you are somebody who has a lot of the characteristics of sleep apnea, one of the #1 symptoms of sleep apnea is what we call daytime somnolence, okay? So people who are tired during the day, a lot of times we find out somebody has sleep apnea because they fall asleep a lot, or they're driving and they crash their car because they fell asleep. So just oxygen is not going to help there. And that's where things like CPAP and BiPAP come in. So, you know, a lot of times someone will do an overnight oxygen study, and if you desaturate a little bit, okay, you can make the case for oxygen. I would still choose continuous oxygen over pulsed oxygen, but given, you know, if you're really substantially, you know, desaturating, and then also even with the oxygen, if you're desaturating during sleep, then a sleep study is definitely in order. And, you know, it's okay for you to ask your doctor these things. So if someone says, you know, if you're going to have an overnight oxygen study, say, is that going to be adequate for me, or do I need a full sleep study? Any other questions?
I have one.
Yep.
It's Laureen.
I know.
You talked very early on about the 90 to 100% of when you check your oxygen is good. But I always go by that scale of 3 either way.
Right. So good point.
I thought it was 95 to 100 that was considered good.
So 95 to 100 is considered normal. Okay.
Okay.
But the scale, okay, and you bring up a good point. So the plus or minus 3. So this is a pulse oximeter. Okay. I'm sure everybody has seen this. Okay. This is a pulse oximeter, wrist worn. This is a pulse oximeter. Okay. The majority of pulse oximeters have a plus or minus 3 error rate. So that means if you're at 90%, I like my patients to say 93% plus, because even if it's reading 93, even if you're getting the negative 3%, you're still at 90. And the significance of 90, as I told you before, that's the flat part of the oxyhemoglobin dissociation curve. So that 90 to 100, those are the 10 feet you have to move back to take your picture of the Grand Canyon, okay? But that 11th foot and that first step is a doozy, okay? That's going from 90 to 89. Now, a lot of times people like to see things in very, very definite terms, very acute black and white terms. So it's not like 89%, oh my God, you're gonna pass out and hit the deck. No. The other thing is, a lot of times I see people cautioning, I hate Facebook, okay? You can't tell because I'm on Facebook all the time, but I hate Facebook. If I never had to go on Facebook, I would never go on Facebook. But I get to meet a lot of people and talk to a lot of people about respiratory disease there. But I see so much misinformation on the internet, and people will say things like, well, you know, once you go to 88%, your organs start to die. Once you go to 80, and it's not like that. It's not like 88%, all right, turn over the hourglass as cell death begins, okay? When we talk about the 6 minutes that people start to experience organ damage, we're talking about a cardiopulmonary arrest, okay? So, you know, it's like somebody had the cardiac arrest. That's the importance of CPR, is to keep things going so that you don't have that 6 minute lapse. It's not that it happens immediately. And it's not like, oh, you know what? I went to 88% 17 times. I must only have 83% of my liver left. It doesn't work that way. But the more you desaturate, okay, meaning the lower you go, the more frequently you desaturate, and the longer period of time that you stay desaturated, the greater chance you have of complications. Now, if you have heart disease, okay, the greater increase in likelihood that you're gonna have coronary ischemia. If you're prone to arrhythmia, the greater chance you're gonna have of arrhythmia. But in pulmonary patients, what we see a lot, especially because the pulmonary circulation is tight anyway, is pulmonary hypertension, okay? And pulmonary hypertension, it doesn't sound that bad when you say it, because people say, well, I know hypertension. How bad could it be? I just gotta watch myself. But pulmonary hypertension, left untreated, or severe pulmonary hypertension, can lead to heart failure, right-sided heart failure, okay? So all these things are connected. It's like, you know, the old lady who swallowed the fly, swallowed a spider, swallowed a bird to catch the spider. You know, everything has repercussions. And, you know, look, I'm not gonna say I'm 100% compliant with everything I should do. I'm probably like 20% compliant with what I should do. But the idea is, you're playing a game here, okay? You're taking risks, and my goal is for you to live the longest life and to live the best life that you can and preserve your organs, and not only that, but improve them and improve your quality of life. So yes, I like my patients to be at 93% or higher, because then even if my pulse ox is the worst pulse ox on earth and it's -3%, I'm still at 90, I'm still safe. But it says 88 as Medicare, you know, Medicare guideline, they say 88 is okay. Or 89 is okay, and I'm -3. Now I'm 86, right? So it doesn't matter if you went 1 foot over the cliff or, you know, 1,000 feet over the cliff. Over the cliff is over the cliff. And it's the same type of thing. And it's hard to get people to understand this about oxygen. And it's hard to convince people to carry oxygen, especially when they don't see the difference in how they feel necessarily. Now, somebody asked before, can somebody get too much oxygen? Okay. I don't think you can, okay? I don't think you can. Now, take what I'm about to say. This is my opinion based on my experience. 27 years as a cardiopulmonary physical therapist. I've been an EMT since 2002, okay? So that's 17 years, okay? I have never once in all of that time, in everything that I've done, ever seen a person stop breathing because they got too much oxygen. And that's what people worry about. And they worry about it particularly with the CO2 retainers. Patients with COPD, it usually is, who retain carbon dioxide because they don't blow the air all the way out. So under normal circumstances, there's something called the hypoxic drive theory. And under normal circumstances, the stimulus to breathe, the thing in our brain that makes us breathe, is high levels of carbon dioxide and pH, right? So those are the two triggers, okay? But the thing is that when people with COPD retain carbon dioxide, okay, it's like, just put your face a little closer to the screen, everybody. So like if I went like this to you, if I just went like this over and over and over again, right? That would be really annoying, right? But eventually you'd get used to it, right? Eventually you'd be able to block it out. And it's the same kind of thing with the chemoreceptors of the body. So in other words, if the CO2 is higher, okay, on a chronic level, what people believe, and it's not impossible, is they switch to what we call hypoxic drive, meaning now it's no longer carbon dioxide and it's no longer pH, but it is now a low oxygen that actually triggers your breathing, right? That causes you to breathe. And the thinking, and again, I believe this is incorrect thinking, I believe it's inaccurate thinking, is that if you then supplement oxygen, you knock out the hypoxic drive and the person stops breathing, okay? Let me say this, I know that there are people who are in acute respiratory failure who, you know, their breathing, you know, becomes more shallow. I've never seen anybody get in trouble either in my practice of, you know, hundreds of thousands of visits or on an ambulance. you know, where I've seen very, very sick or injured people. I've never seen somebody get in trouble because they got too much oxygen. I've seen a lot of people get in trouble because they don't have enough oxygen. Now, a lot of people will say, you know what, you're a CO2 retainer. I don't want your oxygen going higher than 88 to 90. To me, that makes no sense. I've been treating CO2 retainers for 27 years. I give them as much oxygen as they need to maintain saturation, okay? In hundreds of thousands of visits, you would think that if that were the case, at least one person would have stopped breathing, because if you're hypoxic, if your oxygen saturation is 85, 86, 87%, and I put you on this mask at 15 liters per minute to give you 100% oxygen, you would think that I probably would have seen it at least once or twice. I've never seen it. So, you know, the flip side of this is that every time I talk about this and I say what I just said, somebody tells a story about somebody that they know that got too much oxygen, that got too much oxygen, and that made them go into respiratory failure and they wound up in the ICU. I don't know if that's true or not, okay? Maybe they were in respiratory failure and they were going downhill despite the oxygen. So, you know, I would never tell you to counteract, you know, the instructions of your doctor or not to follow those instructions. But I'm saying that I treat patients a lot, all day, every day, for a long time, and I've never seen it. And without that supplemental oxygen, we cannot get the best thing out of you. So if we talk a little bit about pulmonary rehab, okay, a lot of pulmonary rehabs will not supplement you with high levels of oxygen. They won't use masks, they won't use more. And what they do is they'll keep your workload low enough so that you don't desaturate. Anyone have that experience? So if you start to desaturate, they hold you down, right? Or they will make you stop until your saturation comes up again, right? Makes no sense, makes no sense. Everybody wants more Medicare visits for pulmonary rehab. I say let's do better Medicare visits, right? Let's get the most out of each and every workout that you have. And the other thing is that people don't believe that you can improve pulmonary function. If you read the classic literature, you talk to people who are pulmonary rehab experts, they will tell you that patients feel better. They will tell you that they can do more, but they will tell you that pulmonary function does not improve in patients, okay? I know that's not true, okay? Mark Mangus knows that's not true. Tel Aviv University knows that's not true, because we all follow similar types of protocols, which is that we push our patients very vigorously, even if it means giving you 100% oxygen. Why? If your life requires this, and you come to rehab and I work you out down here, you could do that till the cows come home, and that is not going to make you better. But if this is what your life requires, and you can't get there because of oxygen, but I give you enough oxygen, and with that oxygen, you can work out up here, guess what? Your body doesn't know that I'm giving you the oxygen. So you still get the heart benefit, you still get all the muscular benefit, and you get that giant respiratory pump. And that, in my opinion, is how you improve pulmonary function, okay? And, you know, again, I have no reason to bullshit, okay? I do it. This is what I do. I've seen it, okay? And I know there's people I'm looking at right now that could raise their hand and tell you that they followed our instructions and their pulmonary function has improved. So when people tell you that it can't be done, that means they've never seen it done. It doesn't mean it can't be done. I've seen it done, and so I know it can be done, you know? And it doesn't matter if everybody thinks that the world is flat. If it's round, you know, it's round. So the idea is, don't be afraid to supplement oxygen. Don't be afraid to turn the oxygen up. And you know what, the idea, even if we think about hypoxic drive for a second, if a patient were on the treadmill and they were to stop breathing, you know what I would do? I would go, hey, take a breath. End of story. It's not going to happen. The only case where I could really even possibly think that it could happen, if I want to stretch my imagination, is during sleep, or for somebody who's in, you know, real dire straits anyway, and getting a lot of oxygen, okay? But even then, I question that, okay? But during exercise, my feeling is, by hook or by crook, by any means necessary, we need to get the biggest workout out of you, because it's that big workout that is going to make you better and improve your life and allow you to do more. Questions about that?
Noah?
Yes.
I have a couple questions that I'll try and package, and I think they're related. As far as qualifying for insurance, which I really need to afford the equipment, the 6-minute walk test I can pass. I can't.
What do you mean pass?
Well, I can be like 90 to 93. I can't get below 88 because they keep you at a very measured pace. But
You're
when
saying
I exert myself walking stairs or something, I'm down in the low 80s.
Then run.
Yeah, they won't allow you.
Then go to a different place because they're stupid.
Got you. So
Sorry, I know. Listen, no joke. Let's talk about that for a second, okay? 6-minute walk. It's one of my pet peeves. First of all, the test is terrible, okay? And it's done. By the way, if you look in pulmonary fibrosis news today or COPD news or pulmonary hypertension news, you'll see the first part of what I call the Oxygen Manifesto that I am writing with two people that I respect a lot, Mark Mangus and Ryan Deesum, okay? So that's like, you know, I start laying these things out for you, okay? Why is the 6-minute walk test a problem? Let me tell you how the 6-minute walk test is supposed to be done. And now think back to your 6-minute walk test, okay? 6-minute walk test is the patient is supposed to walk as much as they can in 6 minutes, okay? Now, here's some things that could change the consistency of the test. If I only have a 5-foot hallway and every 5 feet I have to turn around, guess what? You're not gonna get the same amount as if you have a 1/4-mile track where the person never has to think. Now, a lot of times places will have you stop so they could get a measurement on you, right? Every minute they'll have you stop, they'll check your heart rate, they'll check your oxygen. No, you shouldn't be stopping, okay? We wanna see what the most is that you could. I don't use the 6-minute walk test unless I'm required to by a research protocol. I have an in-house treadmill protocol that we use that's much better. But the idea is that unless something is dangerous, right? And during testing, I will let my patients go down to 80%. Why? Some people say 80%. If you're going down to 80% on the test, then I will guarantee you that you're going down to 80% in the street, when you're walking up the stairs, when you're walking up a hill. And so for me, I would rather let you go to 80% here, where if I have to, I could give you 100% oxygen. If you get in trouble, I can help you, but then at least we get the information. Frank, by doing it that way, if they never let you go to a position where you drop, they're not doing the test right. I mean, it just doesn't make sense to do it that way because you never get the information. Now, if you're not dropping below 88%, insurance is not going to cover you for oxygen, right? So what would I do? I would have you run. I would have you run it and document the 88%. And that's what they should be doing. That's what they should be doing. I take back what I said about them being stupid. They may not be, but you know, a lot of people just don't know how to administer these tests. And if the test is not administered properly, the data is useless. And in situations like yours, we actually miss the data altogether because you're saying you desaturate. You know you desaturate, right?
Yes.
So what good is that if they do a test and they keep you low enough that you don't desaturate? I hate the 6-minute walk test if you can't tell. But what's your next question, Frank?
When you talk about below 90%, is that consistently over like a baseline, or is it intermittently? Like when I walk stairs and take a shower, I'm in the mid 80s, but normally throughout the day, if I'm at rest or just walking on level, I'm above 90. So when you talk about being below 90, is that with some consistency or intermittently?
What she said was, if it's chilly, okay, and you put on a sweater, if you get warm, you can take the sweater off. And the idea behind pulse oximetry and the idea behind you having a pulse oximeter is so that you can track trends. And this is where a journal is also very helpful, because you can write down the activities of your day and say, well, walking upstairs, I go to 85%. Walking uphill, I go to 88%. Sitting and doing nothing or walking on a flat surface, then, you know, I can maintain 90. But like you mentioned, a shower, if you're 85% in the shower and you take a 10-minute shower and you do that every day, I would make the case that in some ways you are doing damage to your body. And the things I would worry about most are pulmonary hypertension. Now, again, it's not like you're at 88% and then all of a sudden we turn over this hourglass and your organs are starting to die. It doesn't work like that. But if that happens over time, every day, it can lead to complications. And I think that you need to, what we call titrate oxygen to keep you at 90%, okay, or more. So in other words, if you know that you're gonna do something vigorous, or you go to the theater and the theater has a lot of stairs, then you turn it up before you get up the stairs, then you take the stairs, and then when you get to your seat and you catch your breath and you're back at 90%, you can lower the oxygen saturation, you can lower the oxygen again.
Okay, that's very helpful, thank you.
Showering, incidentally, is one of the toughest activities, okay, because of the steam, so keep the door open. Overhead activity is very, very difficult for people with respiratory disease, okay? Why is that? It puts the respiratory muscles at a very, very poor mechanical advantage. So washing your hair, shaving, like you say, how could shaving make me short of breath? But it puts you at a very, very poor respiratory mechanics point of view. The other thing is, I just want to go over a couple of little, like kind of myths. And, this is for the person who I said is hypoxic, even if they're not short of breath. These are the things that people say and do that make no sense, okay? And that a lot of times clinicians will say to patients, and I think it's really misinformation and miseducation of the patient, because they say, I only use oxygen at home, right? So I have patients who have severe lung disease that will use the oxygen around the house, but not use it when they come outside. Again, think supply and demand. Sitting at home is not when you need it. The time that you need it is when you're out and about, when you're going to be doing the more vigorous activities. People say, I only go out down to 88% or 85% or 83%. But again, oxygen, hemoglobin dissociation curve. You say, you know what? I only went 1 foot over the cliff, okay? 1 foot over the cliff is all you need, okay? And again, as I said before, the lower you go, the more frequently you go low, and the longer you stay low, the greater the chance of these different problems. But everybody is different. There's no formula. There's no Rubik's Cube that's going to tell you exactly, or Magic 8 Ball that's going to tell you exactly when you're going to have a problem. If you have coronary disease, okay, then you're going to have much bigger problem, okay, than somebody who doesn't. If you have congestive heart failure, or you have diastolic dysfunction, or you have heart disease and lung disease, or any of these different things, all these things add up, okay? And so for me, you say, well, is something going to happen? I have no way of knowing it, okay? And the other thing is, like, I treat rehab like a flight, okay? I treat my patients, I can know you for 10 years, but I'm still going to take all your vital signs. I'm still going to monitor you very closely, because you're only as safe as your last workout. It's like a flight. You're only as safe as your last flight, right? It only takes one time for something to go wrong. And that brings me to another pet peeve, is that I hear a lot of people who talk about rehab and they say, A, there's no EKG monitoring, okay? In my 21 years in private practice, where we've done about 110,000 visits, we've sent about 100 people to the emergency room, okay? Which is not a lot. Okay, it's like 1 in 1,000, but in 95 out of those 100 cases, it was the EKG that told me there was an issue, okay? Now, a lot of places may not feel they need an EKG because they're not pushing you to your maximum, but that's the next problem. And this is another swallow the spider to catch the fly issue, where it's like, we're not exercising you hard enough, so we don't expect you to really get better, and we may not need the EKG. I wanna use the EKG, I wanna see, and if you take a look over there, you see those blue screens. That means that every time somebody exercises here, I see your heart rate and EKG 100% of the time. So if something goes on, I could catch it way upstream, as opposed to, when you get, and prevent something from getting worse. The other thing is that people say, oh, you know what? They take my oxygen before we start exercise, and then I go through the workout, and then they take my oxygen again after the exercise, right? Anyone have that experience? Okay, so the problem with that is that, again, supply and demand, okay? Of course, before the exercise, if you're having a problem, then you shouldn't be exercising. And after the exercise, the struggle has already gone away. And it's, again, you use the plane analogy, which is that if you want to know how a plane flies, you have to test it in the air. Testing it before you take off and after you land tells you nothing about what happens while you're in flight. So I hope that makes sense. And, you know, initially what I recommend for people, get a pulse oximeter and start to track trends so that you get to learn your pattern, okay? So that you get to know when you need oxygen, when you don't need oxygen. And, you know, don't worry. A lot of times doctors will get a prescription. It's a very standard prescription. 2 liters of oxygen at rest, 4 liters of oxygen with exertion, but 4 liters of oxygen may not be enough for exertion. So use your instruments, okay? That's what I say all the time, rely on your instruments. So like a pilot doesn't know how high in the air he is because air is air, right? It looks the same. A scuba diver doesn't know how deep they are because water looks the same. So water is water. So you have to use a depth gauge, you have to use an altimeter, okay? But in your case, you have to use an oximeter. And based upon those oximeter numbers, that's how you determine what oxygen you need and should you be turning it up or not. I hope that makes sense. Yes.
Sorry, we are over time, so I want to just do a time check with you to see. One thing I would say, like, I'm sure that a lot of people can stay still on, but we are getting a lot of questions on how people contact us. So I wanted to share for a second just a slide with resources so that people, you know, when even review the recording, they can see how to find us. So let me just share really quick. So here is where you can find us at Monarch. If you want to join our patient research network, this is the email address, or sorry, the address that you need to type in, or the URL that you need to type in. And then once you actually join, you can have access to the Connect with an Expert series, the entire series. We will be sending out also a brief email to ask your feedback on how was good, or how good was the webinar, other questions that you might have that we want to get back on. And then like we also put on a few links about Noah's book. We have it here, read it, it's amazing if you have not read it. And also a link to the Pulmonary Wellness online program that Noah and his team perform and have been performing for the past months. And a lot of people ask for my contact or email address. So here it is. When you review and listen again to the webinar, go to the end of the slides and you will find all the information that you guys need. And Noah, I'm giving it back to you.
All right, let's go to questions.
Yes.
So let's go to, I covered almost everything I wanted to cover. Just make a couple of points. Get the pulmonary paper, okay? Because next month, and go to this, and that'll tell you a lot about the different concentrators. Questions?
Noah, I know Mendo is trying to ask a question for a long time. Mendo, I am muted it. I'm muted.
I just wanted to clarify about the too much oxygen thing, because like my doctor does not believe in hypoxic drive theory, but he tells his hypercapnic patients not to turn up too high at rest because it generates more CO2. Isn't that true?
I mean, I mean, if your doctor says it, I'm not going to argue with your doctor. I don't know what is the mechanism for that. What would the mechanism be for generating more CO2? Is it that because you're getting oxygen, you're not taking a deep enough breath and not blowing off the CO2? At rest, your airways should be the most relaxed. I don't know. I mean, I'm not gonna comment on it. I mean, I give oxygen if my patient is hypoxic. Now, that being said, most things, including oxygen and medication, should be delivered on the minimum effective dose. So if you are 85%, if you're 85%, is that me that's making that noise? If you're at 85%, then you are not going to retain CO2 because all of a sudden you're getting supplemental oxygen. You need that oxygen, okay? You can't be at 85%. It's like if you're bleeding, I mean, you have to stop the bleeding. That's what I'm talking about. So if you're ischemic, you have to put the fire out. And you know what, when you feel better and your oxygen goes up into the 90s, then by all means turn it down again. But that doesn't mean you should be taking more oxygen and not arbitrary oxygen. So I'm not saying you stay at 97%. If you're sitting and watching TV and even 1 liter per minute or a half a liter per minute keeps you at 90% or more, go with the minimum effective dose. But I don't see the mechanism how somebody is going to retain more CO2 because they're getting more oxygen. I don't see it. You know, that's my opinion. Everything I'm saying to you is my opinion based on my experience, okay? And by talking to people that I know and trust, and you know, like I said, I've never seen a patient go into a CO2 crisis because we gave them oxygen, and we give people a lot of oxygen. The other thing is, a lot of times people will talk about something called oxygen. You know, Bruce, what I would love to do is ask your doctor how that works and come back to me with it, because I'd love to understand it. I don't see it that way, and I've never had a problem with it. There's another concept that people worry about called oxygen toxicity. And that happens when you're getting 100% oxygen for a prolonged period of time or in a closed circuit. This is something that you would be most likely to see if you're in a, you know, like in scuba divers or in pilots or in people who are in submarines who are at enclosed systems. The home units that people have, none of that is adequate to cause you oxygen toxicity. As a matter of fact, 100% oxygen is the treatment for decompression sickness. In 2014, I had the bends. I was in a hyperbaric chamber for 5 days, inhaling 100% oxygen for 5 days straight. I'm still here. And it saved me, you know what I'm saying? But there's a lot of myths out there. And, you know, I'm going to say just one thing. Like I see this a lot and I talk about this a lot. The internet is awesome in some ways and it's horrible in others, okay? There's a lot of information out there. Some of it's good, some of it's not so good. The pulmonary area of interest has grown a lot lately. Guess why? Because there's all of a sudden money in it, okay? So now everybody wants to get into pulmonary, right? They want to get into pulmonary. People who never did anything for pulmonary before, all of a sudden I'm talking about pulmonary fibrosis and COPD and pulmonary hypertension, right? But when you read an article, right, because I see people sharing stuff all the time, right? Look at who wrote the article. Look at who wrote the article, right? Who do you want to write an article? Do you want somebody who's studied it? It's like I do sharks, a lot of stuff with sharks, right? When I dive with sharks, I want to dive with the experts who have dove with sharks 1 billion times and they're okay. I don't want to dive with the person who studied sharks but that's never been in the ocean before, okay? Or heard about it in school. And it's the same thing with the stuff. So when you see information, don't just share it. Look at who wrote it. Is the person a clinician? And just because it says medically reviewed by Dr. So-and-so, some of these people are getting paid for it, okay? Anything I do, anything you see me write, I'm not getting paid. I'm giving it away, okay? So I have no ulterior motive for doing it. And anything I tell you is something that I've seen and done. If I haven't done it, I'm gonna tell you I haven't done it. If I've heard about it from someone else, I'm gonna tell you who I've heard it from. But look at the quality of the information you get, because there's a lot of people that are talking the same old crap for the same 25 years, and it's just not true, okay? It's just simply not true. And a lot of people, you know, I see that's one of the reasons I dropped the book. You know, I'll tell you, a lot of my motivation in life comes from spite. But it's like I dropped a book for the simple reason that I see all these people using my work and writing a 3-page blog. Right? They're writing a 3-page blog, and anyone could write a 3-page blog. But when somebody talks to you about rehab, or when somebody talks to you about this program that they're doing, or these exercises, or this oxygen, say to them, have you ever done this before? What's your experience with rehab? You know, I don't want the person who's learning on me. You know, it's like, say, go for a colonoscopy. Do you mind if my student does it? Yeah, I mind, okay? So the idea is, look at who's putting the stuff out. Look at, do they have a motive? Look at, are they trying to sell you something at the end of it, like a t-shirt or this, that, and the other thing? Are they trying to get you to enroll in something? Are they trying to get you, you know, look at the motive, okay? There's a lot of—
Laney Mosley, I have a question.
What?
Laney Mosley, I have a question for you.
Go for it, sir.
I have a oximeter similar to the wrist one that you showed.
Okay.
And when I use it at night, it will drop below 90, but it spikes. It doesn't stay there. It goes right back up in a very short period of time.
How do you know?
Does this mean I should be using oxygen at night or not?
Yes, but how do you know?
It vibrates.
It vibrates when it drops below 90. So it will give me feedback and wake me up when I get below 90. But
Lanny,
like I
is
said,
someone feeding you the answers?
No. Well, my wife's here with me.
I know, I'm just joking.
Yes.
I'm just kidding around. I'm just kidding.
But it just,
I thought we were doing a little Cyrano de Bergerac thing here. Listen, if you're dropping, okay, then in my opinion, you should be using oxygen, okay? Because sometimes you can be dropping for, we're counting on the accuracy of the oximeter, but clearly something's going on. So whether it be that, so first order of business is I would ask you, doctor, can you have an overnight oxygen study, right? So if you haven't had one already, okay? If you have an overnight oxygen study, then that should tell your doctor that you are desaturating with sleep, okay? And the other thing about that is that if then you get 2 liters of oxygen during sleep and you don't desaturate, great, problem solved. If you get 2 liters of oxygen and you still desaturate, then we have to go a step further and go sleep study, because then we have to find out, what is it that you're stopping breathing, right? Is it that you're going hypopneic for a while, or that, and the problem, let me just be clear about a sleep study, because a lot of times people talk about sleep apnea and they get this idea that they go into zombie mode and they stop breathing altogether. We have different phases of sleep, right? So we start off in sleep and we have this sort of, phase 1, phase 2, then we go into slow wave sleep, and then phase 4 is what we call REM sleep, which is the restful sleep, right? So it's not that you have to stop breathing for 10 minutes. It's that you can go sleep stage 1, stage 2, stage 3, then you have a little hypopneic or apneic episode and you go back to stage 2. Or you go back to stage 1. Now we start again, stage 2, stage 3. And the problem with this is that you never get to REM sleep, and that's the restful, replenishing, nourishing sleep that we all need.
Well, I've talked to my doctor and asked for the sleep study, but he was not real crazy about doing it.
No follow-up.
There's been no follow-up on it. That's why I'm thinking about changing doctors too.
Listen, if you say to your doctor, guess what? How many times a night do you feel that vibration?
At least 5 or 6.
If you say to your doctor that you are getting an alarm saying that you are hypoxic 5 or 6 times per night, and he doesn't at a minimum do an overnight oxygen study, with the caveat that if that is also poor, that you then, he will supplement you with oxygen. And if that also, then you repeat the oxygen study. And if that doesn't keep you well saturated, that we go to a sleep study, that then, in my opinion, that person doesn't get it, doesn't see that. And the other thing is that sleep is very, sleep is a funny time, because there's a ton of, like hormonal things going on, right? That's why a lot of people have heart attacks right before they wake up, because you get this huge surge of catecholamines, which are like adrenaline and noradrenaline. That's why people wake up and they're like, oh, I'm having a heart attack. In my opinion, I think you need a minimum overnight oxygen study, depending upon what that shows. Supplemental oxygen if you desaturate. Repeat the overnight oxygen study with the oxygen. If you still desaturate, sleep study. You may need a CPAP.
All right, thank you.
Yep. Other questions?
Noah,
Yes.
We have about 5 to 10 minutes. So just wanted to let you know.
Okay. Let me let you know one thing. Okay. I have a Facebook group called Ultimate Pulmonary Wellness, and we also have an online pulmonary rehabilitation program, boot camp. Okay. Where we have these meetings every week. Okay. We have these meetings every week. You have access to me and my team. We give you exercises every day. We give you stuff to do. We'll teach you everything you need to know. And I'm not pitching something, okay? Trust me. I'm not making any money on it, okay? As a matter of fact, I lost all my money on it. But I feel like it's a gift to the world. We will teach you everything you need to know, okay? And you can do it. And there are people who, will really make huge improvements. I think you have to be doing something every day. You have to be doing something every day. But if you want access, you know, we're there. We have these meetings every week where these are interactive meetings. There's presentations every week, every day. So, you know, check it out. It's not expensive. And if you think about your copays or how much you spend on Starbucks every day, it comes out to be a lot less than any of those things. And your health is worth it, and it works. Other questions?
Noah, just a second. For everyone, this group that Noah mentioned, the link to the to where you can find the group is actually on the slide. So you are gonna find it, and it's gonna be easy for you to find it.
PulmonaryWellnessOnline.com, easy. But if you put in my name, question, yep.
Okay, I went to my pulmonologist last week, and the first thing he said is, I talked about was my medications, how I was using them. So I told him. And when I told him I used the rescue inhaler before I go to the gym, which I go to every day, he said not to use it like that, that I should only use that in an emergency. But I'm
gonna do a Saturday Night Live skit with all these questions where, like, I'm gonna be like, stupid. No, no, I'm joking. I'm just kidding. Why, Laureen?
Well, he said that the Brio was long acting.
Okay.
And that I need to use the inhaler.
Maybe you do, maybe you don't. Maybe you do, maybe you don't. Brio is meant to bronchodilate. You're right. It is a long-acting bronchodilator. But there are people who it doesn't work for the full 24 hours or the full 12 hours. The other thing is, in the same way that I told you before about the oxygen, right? If you take the Brio and you don't time it so that you get that full breath into the lungs, you miss the whole dose. So most people don't get the full dose anyway. I went to a conference in Paris a few months ago where they had these charts of how little people, and I was floored by it. I mean, I knew it was a little bit, but when I saw the actual studies, they get very little. But if you need it, you need it, okay? Some people, yes, they're gonna get that booster dose, but then, you know, over time, it starts to get less and less, especially if they're not taking it properly. I see no problem with bronchodilating before, and I feel the same way about bronchodilating before you go out in the cold, or bronchodilating before you do anything. It's like, if you know, like, I liken it to this, okay? If you, what's better for you? Like, would you prefer that? I'm gonna just give you another couple of myths which go along with this. One of them is that people say I only go down for a few minutes, or they say I recover quickly when their oxygen goes down. Like, and they'll ask the doctor, they'll say, I go to 85%, and they go, how long does it take you to come back? 5 minutes. Well, don't worry about it, right? So would you rather, if you were in a glass booth, would you rather I fill that booth up with smoke and then evacuate that smoke quickly? Or would you rather that the booth didn't fill up with smoke? Same type of thing, okay? So when it comes to bronchodilation and airway mechanics, bronchospasm is a real thing, okay? Your airways are lined with smooth muscle. And the thing about that is that the harder you work to breathe, the harder it becomes to breathe. If you think about a pulmonary function test, they ask you to blow out as hard and as fast as you can, because that is what elicits the bronchoconstriction, right? So imagine now you're constricted, right? Now you're working harder. That leads to more constriction and more constriction and more constriction. And that's what we call dynamic air trapping or dynamic hyperinflation, where people get more and more short of breath because they're filling up with more and more air. To me, if I can open it up first, right, with the understanding that we're gonna constrict a little bit, to me, that's much better, okay? Again, I'm never telling anybody to contradict their doctor's orders, but I think the question why is a great question to ask people, because what I notice a lot of times is that people say things and then I ask them why or how does that work, and they have a hard time explaining it. That's my experience. Teresa.
I hope I can make some sense here. I'm actually battling influenza for the last 24 hours. I've been listening very carefully, but again, I've got a fever and so on. Early on, you mentioned hypoxia versus, maybe not versus, along with O2 saturation. I have COPD. The last maybe year, I've been having a lot of arrhythmias, And I went for a colonoscopy on the 14th of March, and they almost would not give me the propofol because she said, which scared me half to death, I misunderstood her. She said, your heart rate's 33. And I'm like, my heart rate's 33. Well, what she was talking about is I was having 33 to 36 premature ventricular contractions out of every 93 or 4 beats. And she was uncomfortable putting me
Were you
under.
by Gemini or Trigemini? Does that ring a bell?
It's actually, she didn't tell me what it was called. I can tell you what it does. It'll go boom, boom, and there's a pause. Boom, boom, then there's a pause. So it's like usually 2 beats, sometimes 2 to 3, and then a fairly decent pause, and it does it again. Like, the only reason I'm asking you this question is I am due to start pulmonary rehab in April at my local hospital with the advice of my pulmonary doctor and my primary care doctor. And I'm just curious if somebody can be hypoxic but still have a normal O2 sat or a relatively normal one. Is that?
No, hypoxic means that their SAT is low.
Okay.
That's that by definition, that's what we're talking about. We're talking about low oxygen in the tissue. Yeah.
Okay.
But the thing is that when you talk about arrhythmias like that or PVCs, first of all, there's a few things that you should think about. Number one, do you have a cardiologist?
I don't yet, and there's been some discussion of that.
So let's not discuss it. You need to get thee to a cardiologist. And the first order of business that I would want to do is I would want to do a 24-hour Holter monitor, because there are a lot of arrhythmias with PVCs, like the one I mentioned by Gemini. By Gemini is every other beat is a premature ventricular contraction, okay? And I don't worry so much about by Gemini because it doesn't change cardiac output that much. But let's say for argument's sake, you may have some periods where you have 30 PVCs in a row or 50 PVCs in a row. 4 or more PVCs in a row is called ventricular tachycardia. And the problem with that is
they said I'd had that before.
That you had ventricular tachycardia. So wait, there's ventricular tachycardia or supraventricular tachycardia.
No, about a year ago, they did an EKG and said I was having ventricular tachycardia.
And what did they do?
They said they pulled me off a blood pressure medicine I was on and said kind of let's watch.
No, I don't think it was VTAC, because that is a lethal arrhythmia. Okay. Ooh. But if that's what you think, you need to find out about that. So first order of business, 24-hour Holter monitor. Let's find out what's going on. How many PVCs are you having? What is the pattern of them? Are you having runs of them? Because first order of business is if you are having runs of 4 or more PVCs, or even, couplets, triplets, which are 2 or 3 together, I want that treated before I want to do any rehab with you. And that can come because of ischemia. So the mechanism is you're ischemic or you're hypoxic, rather I meant to say because of hypoxia. So the mechanism is because of your COPD, maybe you drop your oxygen, maybe because of that, the heart is not getting enough blood flow, or, maybe the heart is not getting enough oxygen. And that could be triggering, very often with PVCs, the issue can be right coronary artery ischemia, because the right coronary artery is what supplies blood to the SA node, which is the pacemaker of the heart. So if the pacemaker is not getting enough blood, then the SA node is not going to fire, and that leaves a lot of time for irritable areas to kick in. But that's something you have to know before you start rehab.
Okay, that's a good point, and I will look into that. Thank you, by the way, for the whole series here. This is
sure thing. Other question? Yep.
We gotta go. Or I'm gonna disappear from this room. Do you wanna keep it open? I'll just okay, keep it open.
Where are you going?
I'm on Joyce on the line. I'm gonna disappear for a second.
No, I mean, where are you going?
I'm going to disappear for a second and come back online.
I can stay. If people want to stay, I can stay.
Okay,
what time
so
is it?
let me just disappear for a second, and
we can also end the meeting from our end. Beth can end the meeting. But I have, it's 3:55. I have 6 more hours. So.
Okay, you have 6 more hours.
No, I have a few more minutes. I have like 20 more minutes if you guys.
Okay, so I'll pop up back online in a second, okay?
Okay.
All right.
Do you guys want to stay or go?
I have a
You want to
question.
stay right? Go ahead.
My question has to do with getting that, the workout that one needs, because
Yep.
I'm someone who, when I started doing rehab, I saw a difference in my pulmonary function test.
Went
So
up
I
or down?
went up.
Okay, great.
And I think it was, it might have been right along the line of right in the range of, was it statistically significant or not, maybe 10% or whatever, but anyhow.
That's huge. Let me tell you this. If we see somebody a year later and there's been no decline in pulmonary function, that's a victory. So if you went up 10%, that's massive. Yeah. That's great.
Okay, and I've wanted to continue that, and I've continued to go. In fact, I've increased to where I go 5 days a week. I was having this conversation with one of the staff recently. I use the training heart rate to be kind of my measure of what I need to be working in. I don't know whether this is true or not, but what I've found is as I've worked more, I've conditioned more, so that I have to work harder to get
that same heart rate. Yep. That's called a training effect.
Okay, which means I have to use more oxygen. Which,
perfect, it's fine.
Well, and I'm sort of at that thing. I'm hearing you mention the mask. I tried that one time. I had a bad experience with it. I still have one there at rehab. I need to try it again because.
What was the experience?
The experience.
Oh, I forgot to show you one thing. This is called a Venturi mask, okay? And this is something that I learned about mostly from Mark Mangus. A lot of people who have difficulty with the non-rebreather mask, who feel constricted with that, feel less constricted with a Venturi mask because they get the sensation of getting a lot more air. But in my opinion, based on what you've said so far, before I cut you off, is that whatever it takes to keep the workout growing, that's what you need to do. And you know, you're only as good as your weakest link. So if your weakest link is oxygen, but your legs could do more and your heart could do more, then give yourself the oxygen. I say to people, sometimes I say, when I'm testing them, I'll say, are you more aware of your breathing or your walking? And if they say it's their walking, then we know it's a conditioning issue in their legs. If it's their breathing, then we know it's a respiratory thing. But yeah, try the mask again. Try to get used to it sitting down. There's also these little things on the side that you can remove, and you don't get that much downside to it, and it gives you the sensation that you're getting a lot. Well, it's not just a sensation, you are getting more air, but that often makes people more comfortable. But if you're working out that much and you're being limited by oxygen saturation, bump it up.
Well, I'm just thinking that the mask will give me more with, I'm right today, this morning when I worked, I had to go to 15 again, which is pretty max for me. I can do
15 on what? 15 on what? A cannula?
Yeah.
It's useless. A regular cannula or a high flow cannula?
High flow.
Okay, so that's better. You sure it's a high flow? 100% sure.
Well, yeah, because it's green and they told me it was a high flow.
Okay, so that's better, but you're still not going to get as much as with a mask, because the high flow cannula is still you're losing a lot of oxygen. Go to the mask, it'll be better. Okay. And you'll probably be able to use less than 15. So whatever it takes you on a cannula, you'll probably get less on a mask. I mean, you'll be able to use less on a mask because you'll get more bang for your buck. But a general rule is, like, once you're using a regular cannula above 6, you're wasting a lot of oxygen and it's very uncomfortable. That's where a mask goes. And the thing is, like, with a mask, you kind of need at least 4 liters per minute. Preferably 6 is where we start using a mask, because, but I showed you before that on 5, on just a stationary concentrator, my mask still stayed inflated. But yes, that's what I would do. Go to the mask.
I do it on 15 if I used a mask.
Nope, not true.
Not true. Showed. Okay, thank you.
Yep. Other questions? Other questions?
There's a Rick unmuted. Did he want to say something?
Rick? Oh, now we know where you went.
Yes,
You went to Siam and Joe.
that's right.
All right. Any other questions? Going once. Going twice. Sold. That's a wrap, people. Check out the article today. Came out in Pulmonary Hypertension News, COPD News, Pulmonary Fibrosis News. Noah Greenspan, Mark Mangus, Ryan Deesum. 2 out of the 3 are smart guys. 2 out of the 3. I'll let you figure. No, I'm kidding. But you could get any 2 of the 3. But read it. We're going to be taking you through all this stuff in a 2 or 3 part series. Okay. So today's the baseline, the intro, and then next time we're going to talk about the different devices, etc. So I'll give you one more chance. Any questions? All right. Thank you guys.
We will be emailing you with information. Bye.
Nice to see you, Em and Joe.
Nice to see you as well, Beth.
Thanks.
Thanks, Noah.
You're welcome.
Thank you.
Many, many thanks.
Thank you.
Thank you,
Great
Noah.
job.
Noah.
Guys.
Thank you.
Good night. Thank you.
Thank you, Noah.
Thank you, Noah. Good night, John Boy.
Right. Good night, John Boy.
See you later.
He's really good.